Very good morning. The topic is labeled as Art of Reading a Scientific Paper. So we will just see how to read a scientific paper as far as a clinician perspective. So a statistician will read a paper in a different way. A clinician will read a paper in a different way. A researcher will reading the paper in a different way. So as a clinician, what I want is some research has taken place in some part of the world. It can be in US or Canada or somewhere that research has taken place. They are claiming that the drug is working in that particular sample size as population. I am seeing an Indian patient. I am sitting in a tier 2 city. My patients are all 60, 70 years old. Can I use the data that is being presented somewhere in the world in my real world practice? That is what I'm trying to give you an overview in the next 30-40 minutes. So what matters in oncology, how statistics matters in oncology is very important is many of the papers, particularly sponsored trials, many of the papers have misleading p-values. So whatever that has been presented to us day in, day out, we see representatives coming and showing some data of particular research work. You can see the statistics has been manipulated in many of the times according to the sponsor's will and wish. So we need to be in a better position to identify which study is good, which study can be extrapolated and used in a clinical scenario. That is very, very important. When somebody presents that the p-value is significant, this drug is working, then probably we need to take a look more in depth into those studies. Really, how significant can we just go by p-value? This is very important. As a postgraduate, when you go into your clinical practice, you will see one pamphlet coming, p-value is significant, this drug is working. So it doesn't mean that we should be using those drugs. So we need to take an extra moment. We need to take another 30 or 40 minutes to read the scientific paper, really whether whatever they are claiming, will it work in our scenario? This is very, very important. And it is important to interpret the survival outcomes, and it is important to see whether these evidence has real value and can be used. So to all the postgraduates, I just want to ask, or you can unmute and speak. What do you see in a paper? Like we see breakthrough papers every day as after ESMO conference, ASCO conference, every year there'll be some breakthrough paper. Or every time you open your Twitter, there'll be one research telling that it's breakthrough. What exactly you see when some news comes like that in a paper? Just type, whether it's an abstract, whether it's a methodology, or you just go directly see the results, or you see the conclusion, or you see the discussion part, because so much is happening every day. 10 or 15 studies are coming out, at least 5 are positive, claiming that it works. So it is very hard to read the entire paper. So it is very important that you do the berry picking. You need to pick the paper which is most importance. Okay, so how do you judge a particular report that a drug works or a results works? How do you judge? What do you really read before going in depth into the paper? Just type in your chat. Is it the abstract? Is it the methodology you see? Is it the results you see? What do you really see in a research paper? Okay, Anbarasan has said check primary endpoint, overall survival, hazard ratio, and control arm is standard or not. Excellent. Very important. So you just don't go by just the results, what finally the author has concluded. You go in depth to see what is whether it's a overall survival, whether it's a progression-free survival, okay, whether it's a response rate they are seeing, how robust is that endpoint. That is definitely important when you look into. Excellent, Dr. Anbarasan. Good. Then I think Dr. Narendran, I think abstract first. Absolutely, because this is the lens, okay, through which you can see the whole paper. So an abstract gives the entirety of the whole article. Okay, so it just within some 350 or 400 words, you will know what the article is. So it helps us to select the paper, what you want to read. So it is very important to read the abstract. But in abstract, again, there is various sections are there. It will be there will be a background, methods. So which session say you will be more you will emphasize more on Anbarasan is primary endpoint, Nitya Priya. Okay, Dr. Nitya Priya. Fine. So to me, I think most of the researchers or most of them who have been involved in research, we all know the most important aspect of a paper is the methodology, how the whole study is designed. This is very, very important. As a postgraduate, I want to tell you that the statistics can be manipulated to get a significant p-value. It all depends about the will and wish of the sponsors. It can be easily done. One is you can get a p-value. Second thing is you can tell it's clinically significant. Okay, so it's very important to look beyond the p-value. At the end of my lecture, if you take this particular thing that we should start looking beyond the p-value as a clinician, I think my job is done. So the heart of the, okay, my slides, okay, fine. So to me, the heart of the paper or any research paper, if you see what is the heart and brain of that research paper, it's the methodology. Okay. The methodology tells how robust the design is. Okay. How credible it is. Okay. So credibility is whether it's a multicentric study, whether it's a single centric study, whether it's a prospective study, whether it's a retrospective study. Okay. These things gives a credibility. Who is doing the study, whether it's a sponsored study. Okay, if it's a sponsored trial, again, the credibility, whether there is any conflict of interest. All these things are very important when you see the study. When the study is done by the pharmaceutical company who has the drug, then again, there is a conflict of interest. How they try to overcome the conflict of interest. So these things, the credibility is very important. Then reproducibility, again, because the study can be conducted in some part of the world. Whether that study is same outcome is reproducible in our scenario. Whether it's a multicentric study, that is important. When I see an Indian patient, when I want to put a drug in Indian scenario, I will always see whether the Indians are involved in the study population. So whether it is reproducible in our scenario, that is very important. What are the biases that is there in the studies? Again, you can see in the methodology, there is various biases will be there. If all the patients lost who lost to follow-up are censored, if the last follow-up is almost 20% or 30%, then definitely something is wrong. Okay, so it is very important to know about the censored data, whether there is any biases. All these things are very important, and this will be seen only in the methodology of the study. So you see the abstract, then in the abstract, if you see, the most important thing will be the methodology. In the methodology only, we can see whether this study can be utilized in our real world scenario and can be used in our clinical practice. Then if you feel that it's good, then you will go for the entire manuscript. You try to read the manuscript. Always remember, when you read the manuscript, there are a lot of things that will be in the appendix. Many of the journals will be giving that. So in depth, it will be given in the appendix, how they calculated the sample size, what is the protocol, everything will be in the appendix form. So if at all you are interested in a paper, make sure that you read the methodology, read the appendix, then you try to draw a conclusion whether you want to give significance to that study or not. So study design overview, I think Dr. Prithu has taken in module 2, excellent module 1 and module 2 both, he tried to emphasize. It was an excellent overview of various study designs he was telling us. So most of us are interested in randomized control trial. This is the most important for oncologists. Whenever we see, you go for randomized control studies, because that is level 1 evidence. When you have some evidence through randomized control study, it's a level 1. So meta-analysis, the first, second is the randomized control, because it gives the causation. It gives the outcome and exposure causation, whether there is any association or not. It takes care of the confounding factors. It takes care of the balance between the groups. So the most important as far as the scientific study is concerned is the randomized control study, is a robust methodology where you can really test the causation or association, whether a drug is working or not. If it's working, which subgroup is working. So we always look for randomized control studies, and we always look for meta-analysis where they try to pool or club various randomized control studies and do a meta-analysis. So these are the level 1 evidence as far as the oncology is concerned. Next is the cohort study, Dr. Prithu has spoken. So cohort study, you follow up the patient. So time factor is involved. So you follow a patient of lung cancer for 5 years. You follow a patient of Hodgkin's cancer for 5 years and see whether they are relapsing or not. So here the cohort is Hodgkin's lymphoma patients. So you are following for 5 years. So time component is involved. What you are checking the relapses. So the event is relapse. So the study group is the Hodgkin's lymphoma patient. Time period is 5 years. And the event you are checking is relapses. So you are checking the incidence of relapses. So incidence rate of the event is you are checking for the event relapses. You are checking for the death. Okay. So your death related to Hodgkin's you are trying to document. Relapses after treatment you are trying to document. These are two events most commonly. If it's a lung cancer, same thing. Lung cancer you follow for 5 years. You see how is the response rate. You see how many have progressed. You will see how many of these are the events. So in cohort study, the time factor is involved where you follow the patient over a period of time. You document the events over a period of time. You calculate the relative risk. What is the relative risk of relapses? What is the relative risk of death due to Hodgkin's lymphoma? You calculate that. So here what happens in cohort, the exposure has happened, but outcome hasn't happened. You need to follow the patient over years to document that outcome. The outcome can be an event. It can be a relapse. It can be death. It can be toxicity. Anything can be outcome. Okay. So exposure is the Hodgkin's lymphoma, patients with Hodgkin's lymphoma. So we should not confuse. Okay. So in epidemiology, they always talk like exposure is smoking and cancer outcome is lung cancer. But in oncology, most of our real world data, it will be the event. Most probably what we will be documenting will be the toxicity, response rate, relapses, death. These are the events which we will be documenting. So this is the cohort study where you follow the patient over years, you calculate the event, you calculate the relative risk, and where you will wait for the event to happen. So a time factor, follow-up time factor is involved. So this is very important. The next is the case control study. Case control studies, both have happened. The exposure happened and outcome also has happened. So this is also some of the genetic studies we use. We use all patients at the time with BRCA positive patients, BRCA negative breast cancer patients. So you take a population where BRCA is positive, BRCA is negative. So one you take it as case and another is control. So here what happens is you calculate the odds ratio. What is the odds of getting a breast cancer in patient with BRCA positive? This is where you calculate odds ratio. So here the time factor is not there because outcome has already happened. Breast cancer has already happened. Okay, so event has already happened. So the follow-up time factor is not there. You take only the event, you calculate the odds ratio. To be honest, most of the statisticians feel odds ratio overestimates if OR is 1.1. It definitely doesn't mean that relative risk is 1.1. Always the odds ratio overestimates, particularly when the event is more than 10%. So odds ratio is not equivalent to relative risk. This you should remember. And it's always good for a rare diseases. Okay, when the event is happening very rarely. Okay, so you cannot wait for the relapses. For example, HR positive breast cancer. You want to follow up for the event. The event can happen even after 10 years. We know that estrogen positive breast cancer patient generally relapse very late, after 5 years, 10 years. You cannot tell that they are cured. Okay, so you need to follow up for a long time where the event happens like ER positive breast cancer, the survival is very good, very few relapses, and relapse happens very, very late. So it's very difficult. So in the other round, if you take a triple negative breast cancer, most of the relapses happen within a year. Okay, so it is very easy for a cohort study. You can follow a triple negative breast cancer and you can follow for 2 years. At the end of 2 years, if you get a survival data, that will be almost equivalent to 5 years data. Okay, because most of the relapses will happen very early. So when the relapses are late, when the relapses are rare, then a case control will be good. But otherwise, when it's common relapses happen in the initial 2 or 5 years, then cohort is good. Then cross-sectional is you at a point you take the cases and you analyze. So here what happens is there is no follow. There is one point you see the patient. Okay, you take all the data. So most of the time it is for the screening studies. For example, you go to a community, you do a mammogram for 1,000 patients at that day, and you want to analyze the results. Okay, so at one point you are doing the mammogram and you are doing. So those are cross-sectional studies where you evaluate the prevalence risk. Okay, so you see prevalence in cross-sectional, you see relative risk in cohort, you see odds ratio in case control. All I want to tell is odds ratio is not equal to relative risk or prevalence risk. Odds ratio is always overestimates, so it is not equivalent. So most of the time in our scenario, what we use is relative risk and hazard ratio. This is what we use. Most of the time it will be a cohort study. So inclusion exclusion. So this is another very important aspect of methodology. Most of the time, what happens is they include only the best subset. If you see all the sponsored trial, only the best subset who will respond, who will tolerate chemotherapy, who doesn't have toxicity, this is the subset they will try to include. Can anybody tell why is this happening and what is the problem with that? You can message and what is the problem with that? Most of the studies, if you see, they will be doing only in the best. They will take only 18 to 60 years, no comorbidities, control comorbidities, PS 0 or 1. This is the subset most of the studies will be taking as far as the oncology study is concerned. What is the problem? What is the problem we are going to have because of that? Excellent. Dr. James, a selection bias. So you are selecting the best subset. Okay. So selection bias is happening. You are selecting the best subset. So the effect size is going to be huge. So they can document that the drug is working in that particular subset. But what happens in our scenario? It's the same scenario. You will put the drug in our scenario, real world data, thinking that this is working. But what happens is most of the patients will not tolerate treatment. They will have toxicity. They will be stopping the treatment in the middle, and we won't be able to continue treatment. So whatever the results they have quoted in the paper will not be able to we will not be able to demonstrate in the real world scenario. This is a problem in most of the oncological studies. You won't have studies for more than 60 years, particularly if you see the lung cancer. Most of the lung cancer, what we get is more than 70 years or more than 60 years. But if you see the trial data, all the studies will be between say 18 years and 65 years, 18 years and 60 years, control comorbidities. But lung cancer happens to a smoker. You will have COPD, you will have a cardiac problem, you will have a decompensated liver disease. So much problems will be there. This is the commonest scenario you have lung cancer. But most of the data, what is presented will be all these things will be excluded. The patient who is PS is 2, PS is 3, who have multiple comorbidities, all these patients will be excluded, and they will try to claim that this drug works. But many of the time, this doesn't happen. So it is very important when you read a study, which subgroup are included, which are excluded, and it's important to see why they've excluded. So this aspect we need to give more importance, and you should see any imbalances there. Particular age group, for example, our population, most of the population will be 45 to 60 years will be the population, most of our population. But in the study, it will be 18 to 45 years. So predominantly younger age group will be involved. So there is a imbalance. Male to female, is there any imbalance? If there is most of them are females and very few are males, can we extrapolate this data to general population? So all these things should be checked before we extrapolate data to our scenario. So if they are both contracting, does not okay. Nityapriya has said if they are both contracting, yes, yes, Nityapriya, we'll come back to the questions in the end. So next is the sample size and power. So all the studies next to p-value, most of us know how good p-value is. Okay, because That's how this scientific or the industry or the business or the service, however, like whoever are coming and telling about a drug, what they talk is only the p-value. But nobody talks about the sample size and the power. So two important things is the alpha error and beta error. Two things Dr. Prithu has explained in his lecture regarding the alpha error and beta error. I still remember one hour to explain alpha error and beta error. Dr. Hemant, actually Prithu's friend, he explained to me once in the first stats decoded with a story of Matilda. So we all know Matilda's story actually. Matilda's story is Matilda, a child. Initially, there won't be any fire. Okay, so she will tell there is a fire and fire engine will come, and she will call it a prank. The next what Matilda will do is next time really there will be a fire. She will call the fire engine, but nobody will come. So the first time what happened is the alpha error. There is no fire, which means there is no association. But she called there is a fire. So she said it's a false positive. Okay. So that is alpha error. So in the Matilda story, what happens first is type 1, where there is no fire, there is no association, but you call it a fire, which means a false positive association you are claiming. So that is alpha error, which is nothing but a p-value. P-value is nothing, a chance. A p-value of 0.05 means there is 5% chance that this can be a false positive. So 95% you may be right. Whatever happening is true positive. But still, you are giving that 5% that leveraged that yes, it can be 5% positive, but I'm going with 95% true positive result. So there is a 5% chance of having a false positive value. That's what p-value. Even robust, you see 0.01 also, some of the trials will tell that it's significant. So you define what is a significant p-value up from the beginning only. Okay, if you see in the methodology, what is significant p-value, they will define. The definition most of them will adopt is 0.05, which means that you accept 5% chance of being false positive. What is 0.01 means? You accept 1% chance of false positivity. Some of the studies accept even 0.1. Okay, some of the studies. So you need to go and check that out. Even if it's a 0.1, they call it a significant, which means that even 10% chance of false positive they are accepting. So which means that 90% they will be true positive, but there will be 10% chance that it can be a false positive. This is about the alpha error. Alpha error is not related to the effect size at all. Remember this again and again, I would like to tell, effect size is different, p-value is different, or alpha error is different. It doesn't mean that if p-value is 0.01, you have larger benefit. No, it doesn't mean. You need to make sure that this particular misunderstanding is out of our brain. If somebody is telling p-value is 0.01, it's highly significant, it doesn't mean that effect size is totally different. Effect size is odds ratio, relative risk, hazard ratio. These are the effect size. So, okay, you want to tell the effect size, hazard ratio is 0.3. It means that there is 70% reduction in the mortality. That is the effect size. That is the effect of the drug. But p-value is just telling whether it's significant or not. Just by telling a p-value is 0.01, it doesn't mean that there is larger effect in the population. First thing you should remember that. Okay, that's the beta error. Beta error is the Matilda story part 2, where it is true positive. It is real. There is a association. Okay, there is a fire. Okay, but Matilda is calling calling the fire engine, but nobody is believing that. So a false negative is reported. Okay, so a false negative is reported. So beta error is there is a association, but we are missing that. So that is the beta error. So beta error is something related to the sample size. So it is very important to understand there is no relationship between effect size and the p-value. Point number one. Next is beta error. It's proportional to the sample size. Okay. So generally the power of the study, what we tell is 80%. So we want to have like 80% of chance that we identify the association if it's really there. Okay, 20% we may miss, but still we want 80% chance to be there. So more the sample size, more will be the power. Always remember two things that determine the sample size. When you're going to a statistician, two things that determines the sample size. One is what is the effect size. If the difference between the trial drug and the standard drug is huge, okay, if the effect size is huge, if you see the response rate is one is 60% in one drug, another is 10%. So effect size is so huge. Then even with a small sample size, the power will be good. Okay. But if the effect size is small, the response rate is 50% in one and another is 45%, only 5% difference in the response rate. Okay. How do you do that? You go to the review of literature, you check all the previous literature, you see how is the response rate between the two drugs, and based on that, you see the difference. So if the effect size is small, then the sample size should be large. If the effect size is large, so if the response rate or hazard ratio or relative risk is difference is huge, then even with a small sample size, you will be able to get the association. So this is the fundamental principle based on which they will calculate the sample size. So this is what I said. So p-value depends heavily on sample size. Is it true or not? Just type whether this hypothesis is true or not. Yes, Prithu, you can unmute and speak, Prithu.
Maybe once they answer this.
Yes, yes. Just answer this question. P-value depends heavily on sample size. Is this right or wrong? Just tell yes or no. Just feel free. Just tell or no. True. One person is telling true. Okay. Anybody else? Nithipriya, yes. Okay. No. Karthik is telling no. Yes. Anybody else? I think others also. James can put. Anish can put. Sindhu can put. Just tell yes or no. You can be randomly right or wrong. Okay. So 50% probability is still there. You may be right. Just tell yes or no. Okay. So we got two of them said true and rest have said yes. Okay. Prithu, you can go on, Prithu.
Thank you. Thank you for that. I mean, I completely, I just want you to understand this well. Either way, I mean, when you find a significant p-value, it may be just a play of sample size, a larger sample size. When you don't get a significant p-value, it may be a play of sample size again, but it's to do with a lesser sample size. So the effect size may be really big, but it may not be significant, statistically significant. When you get a p-value more than 0.05, the effect size may be really big. The difference between two groups may be, say, 10% or 15%. Just because you have conducted a study in 20 patients, it may not show the p-value less than 0.05. It's just a play of numbers. As Arun sir said in his initial talk, whenever you just see a p-value, don't take a call based on the p-value, whether to change or whether what to do. This is where the critical appraisal of evidence comes. What exactly is a sample size? Whether the decision, I mean, whether the effect size is really big to make such change, or is it just because they have a large sample size, the p-value has turned out to be significant. Again, p-values can be manipulated. As Arun sir said initially, p-values can be manipulated just by playing with the numbers you include in the study. What do you say?
Thank you. Thank you, Prithu. So both of you are partially right and partially wrong. Remember, for example, if you have a drug for hypertension, if the difference between the two drug is 1 millimeter mercury, actually this was quoted by Dr. Prithu, 1 millimeter, okay. you can prove that even difference of 1 millimeter is significant. You can get a p-value if you have a large sample size. Okay. So even, yes, difference between the drug is 1 millimeter mercury. Okay. You can get a p-value that is significant by having a large sample size. It partially depends on the sample size. You are right. And remember what p-value you are taking significance also, it is important. Okay. Upfront in methodology, if they tell p-value is what they are going to take significance is p-value less than zero point 0.1. Okay. Even a smaller effect difference will be said as significant because they said that p-value they are going to call significant is less than zero point 0.1. So one is when they call p-value is significant, that is, then you need to go to the methodology and see what are they telling that p-value is significant, whether it's a 0.1, whether it's a 0.05 or whether it's 0.001. That also matters. So definitely p-value has some depends on the sample size. Larger the sample size, then even a small difference can be proved to be significant. But what we need to know is whether it is clinically significant, whether the drop in 1 millimeter mercury is significant for you in your clinical practice. That's what you need to see. For example, one of the pancreatic study, if you all remember, the gemcite erlotinib study, which proved that adding erlotinib to gemcite has overall survival benefit, it came. In that, if you see what is the exact overall survival benefit erlotinib gives, it is only 15 days. When you add along with the gemcitabine, adding erlotinib increases only 15 days. For that, you need to add erlotinib for the patient to almost some 7 or 8 months. Patient to take should take erlotinib along with gemcitabine. They should take the toxicity for that extra 15 days benefit. But the p-values was significant in that particular study. So what we should understand is p-value is significant, but what it is significant? A difference of 15 days, is it significant to you? If it's significant, what is the cost that the patient is going to incur for adding erlotinib for 8 months? These are the things only clinician can understand and take a call. So this is why it is very important to understand the study and to apply the study to our scenario and see how good it is and in our real world practice. The next good habit is to always better to see the confidence interval. Okay. So can anybody unmute? Actually, Dr. Prithu took so much effort to make you understand what confidence interval mean. Okay, so anybody unmute and speak, I think we'll be very happy. Or otherwise, just type in your chat box, what does confidence interval mean? Just type in your chat box. If you're confident, please unmute and speak about confidence interval. We'll be very happy. What does confidence interval mean? Yes, Nityapriya, Priyanka, Anand Kumar, just type what does confidence interval. Nothing, there is nothing right or wrong answer. We are all here to learn from each other. Don't hesitate. Please type whatever you think you understood. Please type. Probability of true value lies within this interval. Okay. Probability of true value lies. Okay. 95 confidence that value lies under the certain limit. 95. Okay. That looks okay. 95% confidence. Thanks, Priyanka. Nitya Priya, Anbarasan, what is your thought? Dr. Sindhu, Anish. Okay. So again, I'm trying to tell you what Dr. Prithu said during his lecture. See, whatever we are doing in our studies, we are trying to take a sample from a population. Okay, if a population is for Indian population is a billion, from among billion population, we are trying to take 1,000 samples and we are trying to study. And this 1,000 samples, we are thinking that they will represent the 1 billion Indian population. This is what we are trying. Whatever the p-value, hazard ratio, all these things are for the sample size. For the sample, what your sample status for what you have taken and you have studied. For that sample, you are giving the relative risk, you are giving the odds ratio, you are giving the hazard ratio. All these things are for the sample. the important questions, what right from my first slide I'm telling is whether we can extrapolate this particular study into my practice, into your practice. Tomorrow, as a postgraduate, you are passing and you're going and sitting in your clinic in Tirunelveli or Tuticorin in a tier 2 or tier 3 city. Can you use this data and put your patients into that? Whether this particular sample represent the population. So that is what confidence interval. When you take multiple sound, the 1 billion population is there, Indian population. You do the study in multiple thousand study samples. Okay, how much variation will happen as far as the relative risk or as far as the outcome is concerned. Okay, so a confidence interval exactly means when you repeat the study multiple times, what will be the variation that happens as far as the event is concerned. For example, if you tell that 20% is the response rate difference and the confidence interval is 5% and 90%. Okay, so 20% is the response rate, or hazard ratio is 0.2 or 20%, and the confidence interval is 0.1 to 0.9, which means that if you draw the sample multiple times and do the study again and again, there will be one population which will have a hazard ratio of 0.1, which means that 90% reduction in the mortality will happen in one population, one study's population. Okay, that is the lower limit. Upper limit of this confidence interval 0.9, I said. So upper limit is 0.9, which means that there will be another sample where if I do the study, I will have hazard ratio of 0.9, which means that only 10% decrease in the mortality will be there. So there is a huge variation. I will not be comfortable at all, particularly if the drug cost is huge, although it is not crossing the null value of 1. If the hazard ratio confidence interval of the study is 0.3, although 0.3 is very significant, because 0.3 you get very rarely you get in any of our oncology studies. 0.3 means 30%, that is 70% decrease in mortality. That's what 0.3 means. The confidence interval is 5% to 90%. So the lower limit of confidence interval is 5%, which means that there is one population which is benefiting hugely. The upper limit is 90%, which means that there is another study population where the benefit is very, very minimal. Okay, so I will be very cautious in using this particular drug in my real world, because there is some population with there is no benefit at all or minimal benefit, and the confidence interval is wide. On the other hand, hazard ratio is 0.3, p-value is significant, the confidence interval is 0.25 to 0.35. It's a very narrow. So even if I miss, if my patient who is sitting opposite to me is one of the bad subset who has the lowest effect of the drug, still he will have a hazard ratio of 0.35, which means that even that scenario, my patient is going to get 60% decrease in the mortality using that particular drug. Okay, so this is how you will read when the p-value is 1. Another most important is see the effect size. When the effect size is 0.3, the hazard ratio is 0.3, or when the relative risk is 0.3, okay, which means there is significant benefit. On the other way around, when the hazard ratio is 0.9, effect size is small. When the hazard ratio is 1.1, effect size is small. Okay, so you see the effect size, you see the confidence interval, narrow the confidence interval, you are happy. If it doesn't cross the null value, then good. Then you see the p-value. This is how you need to go on when you see the manuscript or the study. So these are the various effect size I've been speaking of. So the effect size, how you measure varies from studies to studies. If you see the case control study, you know that both the outcome and the exposure happen, which means in most of our studies, the outcome is death, relapse, toxicities. These are the outcome. Always remember, in epidemiological term, they will always tell that exposure is some environmental risk, and outcome will be cancer. But many of our studies, exposure will be the cancer and the outcome will be the death or relapses. So you need to always separate that out. So in case control study, what the effect you are seeing is odds ratio. This is what you will be seeing. So the effect or the outcome will be in binary: death, not death; relapsed, not relapsed. Only two outcome is possible. Okay, that's why when you do a study in your clinical practice, or when you do a real world also, at the end outcome you will say died, not died. Okay, that is for one column you will have patient has died, not died. Okay, so that is the event. The next is you will try to define the time to death. So what is the date of death? What you are trying to calculate? When the patient was diagnosed, when the patient died. So time to death you will calculate, and you will try to calculate whether the patient died or not. There will be two columns will always be there. Okay, date of diagnosis will be there. There will be one column telling that whether the patient died or not died. Then there will be one column trying to tell when the patient date of death will be there, and date of last follow-up. These four columns are very important when you calculate this effect size. Date of diagnosis, whether the event has happened or not, when did the event happen, how the patient is at the time of last follow. Without these four, you cannot calculate the hazard ratio or survival data. It is very important. If you go for any study, you want to measure your outcome, your patient outcome, you need to have these columns. Then only you can calculate. So odds ratio you calculate for in case control study. In cohort or randomized control study, you calculate the relative risk. Time to event, this is important. So what happens in relative risk odds ratio is only the event component is there. You are not calculating the time component. If you want to know how event has happened, whether the event has happened in 1 year, whether the event has happened in 2 years, or whether the event has happened in 5 years, so that this time also is important in oncological studies. So that can be calculated only by using hazard ratio, where you use the Kaplan-Meier log rank model, Cox proportional model. These are the various statistics we use, where you use the time to event also. Remember, in relative risk, odds ratio, all these things, only the event is there. Patient has died 1 month after treatment, patient has died 5 months after treatment, patient has died 10 months after treatment. The time is not taken as far as the odds ratio or relative risk is concerned. But in hazard ratio, you take the time, progression-free survival, overall survival, disease-free survival, treatment to treatment failure, time to toxicity, all these things, one time component also is added. So when time component is added, that's why you need the Kaplan-Meier curve, you need the log rank model, you need the Cox proportional model. All these things are utilized when time component is also added. So this is the decision tree. So in your when you are doing a study, what is your outcome? Okay, so first you should define the outcome: death, not death. That is a binary. Binary means only two outcome is possible. That is binary. Okay, patient has died, not died. One most common outcome we use: relapse, not relapse. This is the next common outcome in oncology we use. Progress, not progress. Next common outcome we use. So this is the binary. So the outcome most of the time will be in binary. Okay, so when this is there, then odds ratio can be used, or linear regression model, logarithmic regression model can be used. When you add the time component also, you want to see when the patient has relapsed. You want to follow up the patient for over a period of time. Then you use cohort study, randomized control study, and in cohort study you do the relative risk. You want to know when the patient it's not only you are following up the patient, you are following up the patient, you are documenting that the death, you also documenting when the patient has died, what is the difference from the diagnosis to the death. You want to calculate that also, you want to compare. So that you do with survival analysis or Cox proportional model. This decision tree may be confusing for you, but just spend some time when you go back, just see, because you have done some study, means you will understand how a statistician is using various models to calculate the outcome. Okay, because most of the time we'll just go there, they calculate and give it to us. But how they arrive, what test to be done, how it to be done, will this decision tree will be helpful. This is a very simplistic way I have put for the basic understanding. You spend more time in this and try to listen to Dr. Prithu's lecture, module 1 and module 2, and come back to the decision tree. You will understand more. So just a discussion. So just interpret odds ratio is 2.4. Okay, what does it mean? Just tell odds ratio is 2.4. This is the effect size. So just tell me in chat box, what does this really mean? Odds ratio of 2.5, what does it mean? Which study you generally do, and what 2.5 really means to you in your clinical practice? If one study has said OR is 2.4, what really means? Just type in your chat box. Okay, yeah, Priyanka has said case control study, Riya Sabu has said case, excellent. So odds ratio 2.5, it just means that, okay, so this particular, for example, lung cancer and smoker, there is 140% increase or increased odds of getting lung cancer in the exposed group. So smokers have 140% more chance or more odds to get cancer. That's what. So 2.4 means that almost 1 means 100%. So 2.4 minus 1, 1.4. So almost 140% increase is there. That's what odds ratio is there. But generally, we don't use odds ratio most of in our, like very rarely we use for simple reason that it generally overestimates, particularly when the effect size is large or the event is more than happening in more than 10%, generally it overestimates. That is one. Then interpret the hazard ratio of 0.7. What does it mean? Just type in your chat box, what does hazard ratio of 0.7 means? Just type hazard ratio, what does 0.7? Hazard ratio 30% lower. Excellent. 30% lower. So how do you measure, where you measure, which study you measure hazard ratio, and how do you measure hazard ratio? Just type. Just type in which study design you can measure hazard ratio. Okay, what statistical or test will be used to calculate hazard ratio? Time to event, randomized. Yes, randomized control study, cohort study, you will have a Kaplan-Meier. Okay, so most of the time hazard ratio survival analysis we calculate. Cox regression model will be used to calculate. Excellent. Thank you, Nithapriya. Thank you, Tamilarsi. Thank you. So the last point I want to tell is the null hypothesis. This was emphasized by Dr. Prithu too. Always make sure whenever you are seeing the confidence interval, one thing is it should not be wide. Second thing is you should not cross 1. Okay, why it should not cross 1? Can anybody tell why it should not cross 1? Just put in a chat box why it should not cross 1. Why? Okay. So basically, see, if it crosses 1, there is one subgroup having alternate effect. For example, if hazard ratio is 1.1, then 10% of the population is having increased relapses. If hazard ratio is zero point 0.9, it means that 10% of the population is having decreased relapses. Okay, if the hazard confidence interval is between zero point 0.9 to 1.1, there is one population that is having increased relapse. The same study, if I conduct in a different population, in that population, it will have a opposite effect. That is, decrease in relapse also will happen. So, if hazard confidence interval is between 0.9 to 1.4 and it is crossing 1, exactly there will be one population which will have exactly opposite effect. That is even against the scientific principle. The drug works, the drug does not work is different. Drug works in a different way, in the opposite way is totally different. Okay, so in one population it is protecting, one population it is actually detrimental. So when the hazard ratio is 0.5, One thing is the confidence interval, we want it to be narrow. The next thing is the confidence interval, even if it's wide, it should not cross 1. For example, if hazard ratio is 0.6, if the confidence interval is 0.5 to 0.95, that is different. The same confidence interval, if it's between 0.5 to 1.1, I will never use that drug. Okay, because there is one set of population where it is detrimental and it is harmful to that patient. So you will never, and most of the time you see when the null hypothesis or null value is breached, p value will not be significant. If p value is still significant, then you need to look into the methodology. So these are very important concept what I said to you when you're reading the paper. Whenever you read, try to look into these aspects. It will be very helpful. And probably over a period of time, we'll go into automated mode where your eyes will look into all these things. So what all the data you want to see, those data only you will start capturing over a period of time. The biases, I already said selection bias, most common bias. When they include the best subset where they get the largest effect size so that they will get a significant p-value. That's how most of the sponsored trials are done. But in real world scenario, the population, what we are seeing is totally different. So selection bias, you always should have in the mind. Measurement bias. Measurement biases, each, for example, simple as I use ultrasound for response rate. You can use CT scan for response rate. You can use PET scan for response rate assessment. Each measurement with a different imaging will have different response rates. So this is called measurement bias. Lead time bias. Lead time bias is most of the screening studies. I do mammogram for all patients and I calculate survival. Okay, so there will be some breast cancer which is so indolent, even if picked by mammogram, the patient without treatment, the patient will be going on for years. So I do a mammogram today and I diagnose a breast cancer by mammogram. Without mammogram, I select the other study population, okay, and compare. The lead time is from the screening to the patient becomes symptom. That particular is the lead time. That lead time is added to the survival analysis. Okay, that extra time is added to the survival and that difference is captured as a significant difference. That is lead time bias. Last to follow up is most common. In our scenario, when they publish their real world data, 5 years retrospective analysis, 10 years retrospective analysis, you can see they will quote 90% acute leukemia survival, 80% ALL survival. All of us see that. But when you go into that data and see 30% will be lost to follow. 40%. We all know in acute leukemia why a person becomes lost to follow. Because they would have relapsed, they would have become sick and they will not come to the hospital. That is the commonest loss to follow. If 30% are censored and you tell that 90% of the children you are curing, then that loss to follow up bias is very significant. So always when somebody is quoting very high survival rates, always check how much is the last to follow up and how they censored that particular data. So randomization quality is important. Here I would like to tell the intent to treat analysis. Just treat. When you read two analysis, they will tell intent to treat per protocol analysis. Intent to treat analysis per protocol analysis. Intent to treat analysis is the moment you randomize the patient, you analyze all patient. You won't exclude at all. Okay, for example, a patient is coming, you randomize to this particular pembrolizumab arm. Even whether you give 1 cycle or 2 cycle pembrolizumab or you didn't give pembrolizumab, before giving pembrolizumab, patient died, still the patient will be taken for the analysis. Okay, that is intent to treat analysis. But per protocol analysis is total. They will tell that all patients who have completed 4 cycles of pembrolizumab only will be considered for analysis. All patients who achieved PR status, at least partial remission after 4 cycles, will be taken for development maintenance and only that patient will be analyzed. So you see, they are taking the best subset and trying to measure the effect size. That is per protocol analysis. So per protocol always exaggerate the effect size. The same effect we won't get in our clinical scenario. So always see whether it's intent to treat or per protocol analysis. This is very important. Last is there will be easiest way to understand a study is CONSORT flow diagram. Every study, most of the good study will have a CONSORT flow diagram. It will clearly mention what is the sample size, what is the exclusion, why was it exclusion, how many have responded, how many progressed, how many died. All these things will be captured in the CONSORT flow. Try to just spend some 1 minute to the CONSORT. You will have a grasp over the methodology, how it was done. It is very important. Try to look into that. So confounding is, there are various factors why the effect size is happening. A patient is responding not only because of the drug, there will be various other confounding factors. Okay, there will be the age of the patient, it can be comorbidities, what are the other medications they are taking. All these things are very confounding factors which will define the effect size. It's not only the drug. Okay, it is the effects, drug alone is not determining the confounding size. Along with the drug, there are various factors which is determining the effect size. So it is very important to understand. For example, if I am trying to tell 100 patients of squamous cell carcinoma, my survival is 60% improvement, our hazard ratio is 0.6. All patients of squamous cell carcinoma receiving pembrolizumab had a hazard ratio of 0.6. Excellent outcome I had. But if you see, go back and do the analysis, you will see that only PDL1 positive patient in squamous cell carcinoma, they are responding. It's not all patients. This is the commonest scenario what you see. Okay, then slowly only we understood there are certain factors which is increasing the effect size, and there are certain factors where the effect size is not seen at all. So those are the confounding factors. It is very important to take into account what are other factors determining the effect size other than the particular exposure what you are looking at. Okay, so smoking and lung cancer you are seeing, but there can be other risk factors. So smoking along with the alcohol, along with the asbestosis, along with the environmental risk, all other are confounding factors. It's not the same. So it's very difficult to tell directly smoking and lung cancer alone, but we need to take into all other confounding factors also. So how to eliminate the confounding factors? So this is important. So there are two tests already, parametric test and regression model. So parametric test, when it's a normalized distribution, you do the parametric test, and non-parametric test, when the distribution is not normal, use. Anybody can tell how we, simple methodology, how we will tell the distribution is normal or abnormal. Dr. Prithu said in his lecture, I just want to see how you will tell a population is normally distributed. Just type in your chat box. He said a simple way to tell whether to tell a distribution is normal or abnormal. Abnormal. Just type in your chat box. Very, very simple way to tell there is. Can anybody tell how to tell a distribution is normal or not normal? Okay. I think you all should have remembered. He said there is some relationship between the standard deviation and the mean. What did he tell? How much standard deviation should be more or less than the mean in to tell it's normal or abnormal distribution? When the standard distribution is more than half of the mean, okay, that is the simplest way. That is, I think you always try to remember that when the standard deviation is more than half of the mean, then the distribution is normal. Other than that, I think in Jamovi, they even said you can use Jamovi to see whether the distribution is normal or normal. So if it's a normal distribution, you use parametric. If it's not a normal distribution, then other non-parametric test is, you can always go and refer. But the basics alone, we need to remember. Parametric test and regression model. You remember parametric test is a test of association. That is the simplest test. Okay. That's the simplest. Just test the association. When both the group variable and outcome variable are categorical or qualitative, you use chi-square test. Okay, that is the simplest test of association. But what is the problem is it doesn't take care of the confounding variables into concern. Okay, it can tell smoker and lung cancer, a drug and relapse. Okay, whether it works or not, whether there is an association of better effect if this drug is used for this particular patient. This alone it cannot it cannot calculate for the other confounding factors. So if you want to check the confounding factors, your statistician will tell we need to use the regression model. So this is where the regression model will be coming into play. So first you test the test of association. Test of association is unadjusted. You are not adjusting to the confounding matter. What adjusted and unadjusted when statistician speaks, it just means whether you are adjusting to the other variables that is detecting the effect size. Okay, so in parametric test of association, you won't be able to adjust. You will get a p-value, you will get a mean difference, you will get a proportion difference, but you will not adjust. If you want to adjust, then you should go for regression model. Most of our real world cases, our data, we go for regression because there are so many parameters that affects the effect size. Okay, so if you want to eliminate the confounding variable and just see what is the effect of this drug on this particular population, you go for regression model. This is a very simple basic I'm trying to tell. You can always go and look into these aspects in future. So the regression model, two models are there. Linear regression model is there, logarithmic regression model is there. When the outcome is categorical, relapse or not relapse, this is how most of us will do our study. Death or not death, binary, progressed, not progressed. There use logarithmic regression. Okay, this log regression model you use to measure the effect size. When the outcome is continuous, blood pressure, okay, where hemoglobin value, when the outcome is continuous, then you use linear regression model. So you always remember regression model is used to eliminate the factor called confounding variable and to see the effect size. That is called adjusted hazard ratio. Okay, that is what they call adjusted. So always you can tell first they will calculate the unadjusted hazard ratio. Some of the statistician will tell when the unadjusted hazard ratio is less than 0.1, when the p-value is less than 0.1, then that particular variable I will take and I will do the adjusted hazard ratio. This is the commonest way because we'll give 100 variables. So they will tell that we'll check the unadjusted. Then if the p-value is 0.1 less than 0.1, they will go for adjusted. What they are doing is first they are doing the parametric test, then they are using the regression model to adjust. That is called adjusted hazard ratio. So always try to look beyond the p-value. It's very important. I think one take-home message I want to tell all of you is try to look beyond the p-value, look at the effect size, look at the confidence interval, look at the sample descriptive statistics or summary statistics. Actually, this was said by Dr. Prithu. First, look at the summary statistics. Whenever you start a study or reading the manuscript, look at the summary statistics and look at the CONSORT diagram. Then you go for all these things. Make a point looking at the confidence interval. Make a point looking at the effect size. So these are the confidence interval. We already spoke. Make sure the confidence interval should not cross 1. It should be narrow. This is very important to call it significant. And always important, clinical significance is important. A 10 days benefit, it's not clinically significant. How much our confidence interval is narrow and whatever the p-value, a 10 days, 5 days, 15 days of clinical overall survival difference makes no difference to us. Okay, so always look into the clinical significance of all the statistical significance before we put into clinical practice. So due to want of time, I'm skipping all these things. So censoring is important. Always look at the censor data. More lost. Remember, censoring is nothing but you don't know whether the event has happened or not. Okay, so if a patient you are following up for 5 years, a particular cohort, after 1 year they lost to follow up. Okay, the patient will be censored at 1 year, but you don't know whether the patient has relapsed or not. Simple is triple negative breast cancer, you see. Okay, if triple negative breast cancer, if 30% of the patient are lost to follow up after 6 months or 8 months, then you will not capture most of the relapse. Okay, your overall survival will be skewed. So it's always important to see censoring of data, last to follow up data to really see exact survival benefit. So for survival analysis, you use Kaplan-Meier curve. You do the log rank model. And for comparing and getting the hazard ratio, you use the Cox regression model. So that Cox regression model is for survival analysis. The linear and logarithmic also can be used. That is predominantly used to really eliminate the confounding variable and see the effect size. So the Kaplan, when you look into the Kaplan-Meier curve, you'll see stepwise it will be dipping. Each time a patient is lost, you will see one step. The patient will be dipping. And whatever the vertical tick, what you are seeing, you will be seeing a vertical. Ideally, that also should be put actually, but none of them are mentioning that. Vertical tick, whatever you're seeing, means that at that particular point, a person has been censored. We don't know why they are censored. If more vertical marks are there, it means that a lot of censoring is happening. We need to be very careful when we look into the data. So log rank model is used to compare two survival curves. For example, progression-free survival of two arm A and arm B. Then whether it's significant or not, you use the log rank model. And Dr. Prithu said that you can see the last C column whenever the curve is crossing. Okay, whenever the curve is crossing, a different way of calculating the effect size is required. So whenever the curve is crossing, we need to be very careful. It's not the same because the patient initially they are not doing well. At a later point of time, the patient is doing well. This is commonly seen in immunotherapy. Initially, patient will be we will be losing most patient on the immunotherapy arm, but at a later date, the tail will be prolonging and it will be crossing. It is commonly seen in immunotherapy studies. So whenever two curves are crossing, a different model is used to calculate. We need to be very careful when you see that. Most important is just see the curve. If the curves are separated, then it means that there is a significant effect size. If the curves are not separated, it's overlapping, then there is not much of effect size. So Cox proportional hazard model, it's again multivariate regression model. Again, it is used for adjusting the hazard ratio. Log rank model doesn't adjust, but when you use Cox proportional hazard ratio, so you can adjust according to the various other predictors, other confounding factors that is playing its effect on the outcome. So for adjusting the hazard ratio, Cox proportional hazard model is used. So incidence density, you calculate the incidence rate. For example, I'm following up 5 patients for 10 years or 10 patients for 5 years. So almost 50% years I'm following. So how much is the incidence? So 10 relapses happen. So 10 relapses for 50% years. That's how incidence is. So you calculate the person you have followed, how long you have followed, and you calculate the rate here, and then you calculate the event per person years. That's the incidence rate. This is how we calculate the incidence of relapses, incidence of death. All these things are calculated based on the incidence density. So choosing the correct test is important. When it's continuous, t-test or linear regression is used. When it's both are categorical, chi-square or logistics model is used. When time to event, you are not interested only the event. You want to calculate when the event has happened, how many months. Then Kaplan-Meier log rank and Cox proportional model is used. So this is just look into it. When you go back to your own research, you will understand it better. So common postgraduate errors: ignoring the confidence interval, over reliance on the p-value, wrong test choice, okay, and ignoring assumptions and censoring. This is the commonest postgraduates or beginners who commit the errors. It's always important. We need to have a look into all these 4 factors when you look into our own study or other study. So checklist, check the design, check the sample population, look for biases, look for the power sample size, what test has been used, what is the effect size, how much is the confidence interval. In the end, never miss how much relevant to your clinical practice. This is the most important thing. So with this, I thank all of you. I think I just rushed because of want of time. I just try to summarize what happened in module 1 and module 2, how we can apply whatever we have learned in module 1, module 2 in our clinical scenario. That's what I try to bring it up. So thank you very much. So Prithu, you want to add anything or just your thoughts, final thoughts on?
No, excellent session. I mean, I think it gave a overview. I mean, there is no, I mean, I personally feel there is no need for additional lecture on critical appraisal and other things. However, we'll just go through some slides.
Thank you.
What This overview is important when someone looks into a evidence which is presented in a manuscript. So whatever is published is not sacrosanct that everything is correct there. Always question the sanctity of even the published manuscripts in the best of the best journals. There are a lot of pressure for publishing. There are a lot of pressures for um, from the researcher end. There are a lot of pressures to publish, and from the funders, from the interested lot, there is a lot of pressure to publish in a so-called good journals with heavy article processing charges. So it doesn't mean that something is published in a journal which has an impact factor of 8, 9, 20, 30. It doesn't mean that everything is right or that needs to guide the practice. It's not so. Always review it and then take a call on it. There are some questions in the chat box. I mean, how are the confounding factors identified in a study? See, our interest is not to find the confounding factors in a study. Always our interest is to see the independent effect of our exposure or independent effect of our intervention on the outcome of our interest, right? What these confounders do is basically they distort the effect of the exposure or the independent variable. So in that context, what needs to be done exactly is list these confounding variables. How you will list the confounding variables? You you review the literature, you find similar studies where they have they have reported on, oh, these were the confounding factors, we included them in our model, whatever. Include them in your study also as the variables when you collect. Once you have that, you have a profile of patients, even in terms of the potential confounding variables. And in case if you are doing something very new, always based on your clinical practice, think what may affect the outcome other than your intervention or the exposure. Just include them, capture them quantitatively. Once you capture them, you have the profile of your exposed, unexposed, or those who have received the intervention, those who have not received the intervention. You have the profile in terms of the confounders also. And once you have this, what you can do is you can include them in the regression model to see the independent effect of your exposure or the intervention. See, none of the studies are like there is no study where you can tell that there are no confounders. Definitely there will be confounders because it's not always A causes B. There are C, D, E, F which may contribute to B. So always think of these other variables which can have an effect on the outcome, include them as a variables in your study and adjust them during analysis. One of the advantage with the RCTs is when you have a larger sample size and when you do random allocation to the drug and or intervention and a non-intervention group, the confounders automatically get dispersed evenly between the two groups. Okay, that is one way of minimizing the effect of confounders. Include them in your study, adjust them wisely, and get the independent effect of the exposure or intervention which you are testing.